Hello, and welcome to this edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me today, well, I'm glad to have him back, Dr. Bhaskar Purushottam with Monument Health, the Heart and Vascular Institute at Monument Health. And joining him is also Roger Deraad, who is the Director of Research. You were the Director of Research. Are you still the Director of Research?
Yeah, I still work in research
Okay.
as one of the investigators.
Investigators, all right. Wanted to make sure I got everybody's title right before we moved on here. Dr. Purushottam, of course, people were first introduced to you back in episode 60, I believe, of the podcast. We were talking about complex coronary diseases, I believe is what we discussed.
That's right.
So if you'd like to go back and get all of your background, we've got it on there for sure. Today, though, we're going to talk a little bit about how you two work together. Roger, you were here earlier, and I got to sit down and just talk with you a little bit about your background and what it is that a clinical researcher does. Because again, that's a title I think a lot of us see in articles when we're talking or reading about medicine, but I don't know if we really know exactly what it means. So can you just kind of give me a little bit of your background and how you kind of became a clinical researcher?
Yes. I think most people that end up working in clinical research don't start out with the intent of working in clinical research.
Sure.
None of my staff, myself included, and probably none of our investigators who now work with us at Monument Health really thought they would be clinical investigators once they got here. So I'm a nurse. I went to graduate school at the University of Washington in Seattle, and there they have a strong research background. So we all had to do a thesis. I worked with many people in the intensive care unit there that were also in graduate school working on their own theses. So we're steeped in research. And it's interesting, of course. All research questions are interesting. And so when I came back here and began working with the heart doctors back in 1994, one of the physicians here at that time had started a couple clinical research studies and asked for my help. And then we picked up another study and then another one. And finally we had to sit down and decide, okay, are we going to do clinical research here or not? And we decided to do that, and we've taken and grown the program over the last 25 years. There's 19 of us now doing clinical research. So we've slowly grown the program. And our role is to provide an infrastructure so that any physicians working at Monument Health that are interested in participating in clinical research studies that are going on, we provide the infrastructure so that they can do that.
So then how does cardiology fit into all of this, doctor, for you? How do you get tied into this clinical research?
But before I answer the question, I really want to commend Roger and his team, for building this phenomenal research division. Having trained in big academic institutions like Mount Sinai in New York and William Beaumont, I think with the limited resources Roger has had and achieved, it's just incredible. So I had to start off with that.
Great.
Once I got that off the chest, that's the truth. I did 6 months of research in William Beaumont, so I had a flavor for it. And throughout my residency fellowship, I've been publishing. And after I came here, I was really impressed with what Roger had set up. And knowing that in the field of medicine, if you open up any of the major journals, most of the research, funding and innovations, you see a lot in cardiovascular, oncology, and a few other departments. And I realized that with the challenging patients we've had in cardiology, I think it was absolutely important to have some of the cutting-edge technologies to involve our patients in this, because this way, once the physicians are involved, you kind of get obligated to get yourself updated. Mm-hmm. You got to know about the disease as well as the treatments. So in turn, this actually helps the patients. And that's how with different diseases, Roger comes up with us and says, hey, these are the trials involved. Let us know if any of your patients enroll. And I'm like, oh, yeah, this patient will truly benefit from this. So we really work hand in hand. Pretty much every other day, we have a sign out or a handoff saying, hey, these are the patients admitted. These are the patients we're seeing in the clinic. And they give us an update every month. And also now they have an app which shows all the
Oh,
list
really?
of trials. So we really coordinate and work excellently.
So are you? I guess I kind of was talking to Roger a little bit earlier. You know, in a market like this, size-wise, really, I was really surprised at the number of clinical trials that happen here. Is that surprising to you, Doctor? I mean, are you surprised for an area of this size?
Yeah. When I came here, I was really surprised.
Really?
But when now that I'm 8 years here in practice, I clearly see that we can build a way bigger department, and we can also try and put some more weight to get in more funding to initiate studies which originate from Rapid City.
Right.
I think we have the potential for that. You know, we definitely need a little more manpower.
Sure.
And we don't want Roger to retire. You know, that's the key thing.
Well, I just want to let you in on a little secret, Doctor.
I know.
We had a conversation. So, do you guys when you're working together? Do you guys? There obviously must be things that you guys get excited about and promising developments and breakthroughs and such. And again, I was surprised to kind of get some background on all of this, the clinical research studies. Is there some that have caught your attention recently? Some breakthroughs and some stuff that's being done right here in Rapid City that you specifically, Doctor, are excited about when it comes to our hearts?
Oh, absolutely. I think the biggest thing, especially, is being an anticoagulant, antiplatelet therapy, which is often used in coronary artery disease. You know, whether you receive a stent, you don't receive a stent, or you undergo a bypass. It is well defined that these drugs really alter the person's survival. And we always had challenges with some of the older, you know, the antiplatelets or the blood thinners with bleeding and other complications and not able to achieve that kind of mortality. And you know, Roger and his team have come up with multiple new strategies to treat them. And that's something which is very exciting to me. I think, you know, as we talked in the last podcast, you know, interventions are great. I enjoy doing them. I help the patients. But truly what changes the patient's survival, long-term outcome, and can be implemented in a mass is truly medications and lifestyle. Would
you say that those anticoagulants, because Roger, we'd also talked a little bit about this and some of the new exciting studies that are coming out, is that quite possibly one of the most important things when it comes to your heart and the surgeries?
Oh, yes.
and the really?
Yeah,
why is that?
I think that forms the basis whether you receive a stent or you don't receive a stent.
Oh.
I think having good medical therapy forms the base, period. I mean, no questions asked.
Mm-hmm.
I mean, it is only when they fail medical therapy we start to implement interventions. But again, you know, it varies patient to patient. So
right.
I think having critical medicines, you know, guideline-directed therapy, as well as certain options, because not every patient fits into a trial.
Right.
You know, a lot of patients who don't fit in the trial. So that's where it's important to have some of these novel drugs which we can use on these patients.
Now, is it specifically, a lot of the trials, Roger, that you do, are they specifically drug related? Is that all that is? Does that question make sense?
Yeah,
in my brain it does, but
probably at least 2/3 of our trials are drug related.
Right.
The intervention is a drug, but Dr. Purushottam and Dr. Tuma and some of the other doctors have worked with devices also.
Okay.
Like stents.
Yes.
Valves, things that are.
Do those change drastically? I mean, it seems like a stent is pretty much it works, right?
Yeah,
Are there lots of changes that can happen to that where clinical trials would be needed?
Yeah, you know, they're trying to come up with newer kinds of stents. For example, once you get a stent, you got to be on the blood thinners for at least 6 months, 12 months. Now they're coming out with newer stents where you can just get away with 1 month of blood thinners, so you can get your stent and you get your surgery.
So
in the
much
second
faster
month.
then.
Much faster.
Okay.
And things which will stay open for longer so they don't close down quickly. And also trying to see if they can modify the disease where the patient can live longer, you know, by reducing the number of reinterventions. So they do make an impact. Absolutely.
Okay. Well, obviously, and I still think that's the case, that cardiovascular disease is the leading cause of mortality worldwide, right? There obviously has to be a lot of challenges that researchers like you, Roger, face. Are you guys? How do you mainly address these challenges that you face? Is it just finding the right people, finding the medication, going to these conventions and stuff that you talked to a little bit? Is that kind of your first line of defense in this?
Challenge-wise, I think all of us are busy.
Okay, well, sure.
Our physicians, and we are. So there are more trials we'd like to do than we can possibly do. So we really need to build the right size team, and then take on as much work as we can, and pick the trials that have the biggest impact on our community and the ones that our physicians are excited to be working with.
I suppose you have to do kind of focus community-wide. You really have to know the people that you work with. These aren't trials, not just to use the term generic. They're not just generic trials. They're pretty specific in most instances of people that are here, right?
Yes.
The population we live with around here, for sure.
The trials we're interested in doing are the ones that affect the people we work with every day.
Right. Okay. Well, there's you talked, I think, a little, Doctor. You mentioned that kind of that patient-centric approach too. So how are a lot of these kind of being applied to cardiology and that impact that they have? How does that?
I think we can see that in the last decade or so, that the focus has not been on a test result. The focus should be on a patient-centric result. Like, has this improved the patient's survival? Has this improved the patient's quality of life? As opposed to saying, hey, has the stent just stayed open? It's great if it's open, but it's even more greater if the patient's symptoms are improved. And actually, you can see a lot of large-scale research studies are starting to focus on that. A good example is the Google's breakaway decision, the Verily Sciences. And they're trying to build a database where you can go ask a patient-centric question, and you can collect all the data on a very, very large scale.
Well, explain kind of what patient-centric means.
Okay. So, for example, if I have a patient who comes and sees me for chest pain, and we've tried medical therapy, so we go ahead and we find a blockage, we put a stent in, okay, and then we follow him after 2 months, and we see that his stent is open. So that is a test result we're looking at. But if he comes and tells me, doctor, I feel better, I can now walk 4 miles, and my quality of life is improved. And so that is a patient-centric, as opposed to just saying, is the stent open or not? So the idea is to see, is it helping the patient clinically, which is the most important thing.
So that really is where we're headed, isn't it, in your guys' field, is that patient-centric, more so than just you took the drug, did it work, fine, right? Does that change things up for clinical trials too, that patient-centric approach a little bit? Or are you simply working and looking for that end result?
In clinical trials, I would have to say that more.
Sure.
Because people, to be in a trial, you have to fit the inclusion criteria and the exclusion criteria. Of course, along the way, we're looking for patients who are compliant, who are getting the best standard of care, because we're trying to add therapy above the standard of care. So we kind of have to pick the patient with all those variables playing in.
Sure.
But research is volunteers. Everyone in research is a volunteer. So it's patient-centric, and those people are deciding that that's what they want to do.
Do you find that it's easy to get volunteers, doctor, when you feel like you have somebody that you know is just right for the clinical trial? How hard is it to convince them to do it?
It is tricky,
Really?
It depends on the patient's relationship with the healthcare system, with the physician, what they've gone through, and what level of disease they have, and to being absolutely truthful. Hey, this is what we are dealing with, and but most patients, I think, understand.
Yeah.
And I've seen when explained well, and when given the appropriate circumstances, I think they seem to agree to it and willing to cooperate.
Have you ever come across a patient that you knew was just perfect, and you wanted them in that trial, and they just didn't want to do it?
Oh, absolutely.
Have nothing to do with it?
Yeah, there's always that. And I understand that, because...
Well, sure.
Yeah, because each one has their own right to make a decision.
Right.
And I completely respect that. Yeah.
But I guess if for me personally, if something was wrong with my heart and I needed to get it fixed, and you said, look, you've got a clinical trial, I don't know how I could say no to that, right? But I suppose, like you said, everybody's an individual and everybody has their, well, kind of moving into like the technological integrations too, that we were talking about just how, and I think you and I talked about it too, Doctor, on the last podcast, of how quickly these technologies change. You guys, it seems like you can barely catch a breath before something comes along that you're interested in, and you're like, wow, here we go. This is what I've been hoping for, right? Are there any like specific tools or platforms that both of you find super promising that's coming up that you're really excited about? I mean, you can see it, but you got to test it first, right? You get to be on the outset to be like, hurry up and test it because this looks cool and this is what I want. Do you guys have things like that you're excited about?
Good, Roger.
Always. One of the things technologically, we already mentioned Verily, which is part of Google.
And can you explain that really quick, what that is?
Yeah, Google has a lot of different areas they have focus on, and health is one of them.
Sure, okay,
Verily is.
Oh, got it. All right, perfect.
Part of the company focused on that. So we worked with them a little bit, talking about doing decentralized research, which means places like us, which are rare, yet if you want to be in a research study, you need to be here,
right,
or Omaha, or Mayo. It's not available to everyone. So decentralized is trials that are run, and maybe advertised isn't the right word, but the knowledge of the trials is spread maybe through Google, who also has knowledge of what that population in areas looks like. So you can, when you open up a new trial, you can be a part of that no matter where you live. Now, that doesn't work for all clinical questions, but some clinical research you could do in a decentralized manner like that.
Right.
Be available to many more people. And they've done a lot of work, and people are interested in doing that. So that's one way, because we got to get the price down. It's just too expensive and too localized, because we want it to be generalizable to the whole country. So we want everyone from all over the country participating, ideally.
Is that kind of how you feel about it too, Doctor? Same thing?
Absolutely. I think it's great to do some real advanced research, but research costs a lot of money, and the expenses just going up. And number two is not every institution is willing to invest that kind of time and money. You know, I have to try and take care of my clinical duties, number one, and then find my spare time, sometime after hours or weekends to do this research. So obviously you have to find a way where it's economical and time efficient, and that's where technology comes in. So I think what Roger says, decentralized, is so critical. The new phrase in medicine is data is gold. I'm sure it probably applies to everyone.
It does. Media, to us as well. Same thing, sure.
And if you think of it, if we have accumulated data of, say, the last 10 years of our Native Americans with cardiovascular disease, I mean, we can learn a lot from it. And so if you can pool this data on a large scale throughout the country, I think it's going to benefit every single one of them.
So does AI technology play a little bit into this too? Do you guys find this at all for clinical trials? Is it helping?
We've done trials utilizing AI, a couple of them with Mayo, where they were looking at EKGs, and can we look at EKGs and make a assumption about the left ventricular function. So that's when we recently helped them compile data to build an AI model to look at that.
All right, well, let's talk a little bit about the collaboration that you guys do, and I'll let you compliment each other profusely here a little bit if you'd like to. I mean, you guys, I before I started this podcast and looking into it today as I was getting ready for it, I didn't know how clinical research worked. I didn't know how closely you work with the doctors and vice versa. I thought a clinical trial was the pharmaceuticals have created the product, and they go to the clinical trials to test on patients. I mean, doctors obviously would kind of be involved a little bit. But you explained it to me that you really do work closely with the doctors when it comes to the trial's beginning and ending and the results, right?
Oh, you bet. We meet monthly with what we call the principal investigators, our local physician that's running the trial. So we meet monthly, talk about who's enrolled in the trial, go over the lab work that's been done, look at the EKGs, whatever's pertinent to that particular trial. So yeah, what the patients really enjoy participating in trial is good follow-up.
Yeah.
They see a health professional pretty frequently. If they're having problems, we interface with either their physician taking care of them or the principal investigator of the trial, because we need to ensure that our patients in trial are getting the best possible standard of care before we can say that the intervention we're doing adds to that.
Right.
So if their blood pressure is uncontrolled or if they have congestive heart failure that's suboptimally controlled, we work with everyone else taking care of that patient.
Okay. So, doctor, then how does it start for you? How do you work with Roger?
The way it works is, we kind of are at the front line, and we see what are some of the burning questions, some unanswered questions, and what is relevant to this community, and we try to bring up those questions with Roger, or Roger brings up a trial, and he asks, hey, do you think it's feasible? Is it? And then we say, oh, this is a great trial. It fits the needs for our community, or this does not. All right, if I bring up a question and then Roger says, hey, it's just logistically not feasible, we might just invest a lot of time and we won't get the best of the best results. And so you really have to pick and choose, not really cherry pick, but see what suits the community.
Sure.
Absolutely.
Yeah.
And that's the most important thing to doing a successful trial is picking the right trial.
Yeah, absolutely.
And at the very end, it's picking the right patients.
Yeah. So do you have patients that maybe, doctor, approach you and say, I want to be part of a trial? Is there anything that you can do, or because maybe they have a condition that is not promising, right? And they come to you and say, what can be done? Is that something then you can help? I mean, what are your options in that situation?
I mean, yeah, we do have patients who come and ask us, like, do you guys have any trials for this condition? Because and we look around, we investigate, we ask, and if not available here, we do guide them, across the country. Yeah.
Oh, that's very helpful.
Oh, it
sure.
is. Absolutely. Yeah.
We mentioned an app, and
yes,
I
just wanted to talk about that.
We can get that out.
Yeah,
and that's an app that anyone can access free of charge, and on that we list all the trials that we're doing. It's difficult to communicate because we start up to 15 trials a year, and about the same amount are ending. So it's very difficult to communicate with everyone what's going on. I can barely keep track. And so we just started using this app so our practitioners can look at what trials are going on, what's the inclusion-exclusion criteria, and people in our community, I believe, can access it also.
Oh, that would be super helpful. So we'll make sure we get the word out for that.
Neat. Yeah,
and throw that in on the podcast too. And
Dr. Purushottam is our medical advisor. So when we get new trials, he's one of the first people we bring them to go, all right, will this work with our practice, and will this work with our community?
Well, it is, and I've said this a couple of times on the podcast. I'm so relieved talking to the doctors I've talked to with Monument that this stuff exists here in Rapid City, because so many times we think we've got to go to Denver, we've got to go to Minneapolis. We have to leave the area. And as a patient, that's one thing you never want to have to do. And as a doctor, you want to keep them here too. It just seems like the rates of recovery improved drastically when you could sleep in your own bed at night in a lot of instances, right? So I want to thank both you guys for coming in and talking about this. It's Roger Deraad, who is the Director of Research for Monument Health, and of course, Dr. Purushottam as well. Thank you, cardiovascular cardiologist with the Monument Heart and Vascular Institute. Jeepers creepers. I was practicing that all day again. I don't know why. I've said it so many times. Anyway, thank you both for coming in and talking with me.
Welcome.
I appreciate it.
Thanks for inviting us.
Thank you. Appreciate it.